Okay, let's jump into some CNS neuro-oncology cases. We'll focus on benign tumors and how we use stereotactic radiosurgery, SRS, looking closely at dose selection and evidence.
Sounds good. Ready to work through these?
All right, first case. We have a 50-year-old woman. She's noticed several months of hearing loss, progressive, just on the right side, high-frequency sounds mostly, and tinnitus. Audiogram confirms it's sensorineural. So, CPA mass. What's on your differential?
Okay, cerebellopontine angle mass. Number one is going to be vestibular schwannoma. That's the most common by far.
Right.
But you also have to think about meningioma, second most common, and less likely but still possible, an epidermoid cyst.
Good. And imaging. What do you absolutely need to nail down the diagnosis and plan treatment?
Definitive imaging is a high-resolution brain MRI, with and without contrast, obviously. But for planning, especially for SRS, the key is the high-resolution T2 sequences.
Tell me more about those specific sequences. Why are they critical?
We're talking Fiesta or CISS sequences. These are really important because they give you incredible detail of the cranial nerves, 7 and 8, through the internal auditory canal, the IEZ.
So you can see the facial nerve course.
Exactly. See the nerve, see how far the tumor extends into the fundus of the IAC, and crucially, pinpoint the cochlea's exact location. You need that detail for hearing preservation planning.
Absolutely critical detail.
Yep.
Okay, the MRI comes back. It shows a 2.2 centimeter avidly enhancing mass centered right on the IAC. It's a vestibular schwannoma. Hearing is serviceable, Gardner-Robertson class 1 to 2. What are her management options now? Compare surgery versus SRS.
All right, so her options are basically threefold: observation, microsurgical resection, or SRS. Given the size, 2.2 centimeters, it's kind of in the sweet spot for SRS. Usually less than 2.5 to 3 centimeters is considered ideal.
And why SRS over surgery here?
Well, SRS offers really high tumor control rates, like 90 to 95%, which is comparable to surgery long-term for this size. But, and this is key, it generally has markedly lower rates of significant complications.
Specifically, which complications are lower with modern SRS?
Primarily facial nerve and trigeminal nerve neuropathy. Historically, SRS doses were higher, maybe 16, 18 gray, and facial nerve issues were more common.
Right.
But modern practice, guided by groups like the ISRS, uses lower doses, typically 12 to 13 gray. This maintains that excellent 90 to 95% tumor control, but really drops the risk of cranial nerve problems down to low single-digit percentages. Much better profile.
Okay, excellent. So walk me through your SRS plan. Dose, isodose line, key constraints, justified.
Sure. I'd prescribe 12.5 gray delivered to the 50% isodose line.
12.5 gray to the 50%. Got it.
The GTV, gross tumor volume, is the enhancing tumor itself. For the PTV margin planning target volume, it's minimal, 0 to 1 millimeter. The absolute critical constraint here is the cochlea.
For hearing preservation.
Exactly. We must keep the mean dose to the cochlea at or below 4 to 5 gray. That's the goal.
Okay. Other constraints.
The brainstem point dose needs to stay below 12.5 gray. It's single fraction tolerance. Then, follow-up. MRIs at 6 months, 12 months, then annually. And importantly, you have to counsel the patient about possible transient swelling or pseudoprogression on MRI in the first 6 to 12 months. It can happen. Doesn't mean treatment failed.
Perfect. That's a great summary. Teaching pearl number 1. For sporadic VS, with serviceable hearing, 12 to 13 gray SRS is standard, and that cochlea mean dose under 4 to 5 gray is paramount for hearing.
Absolutely.
Now let's throw a curveball. Same presentation, but the patient is only 25 years old. And the MRI shows bilateral vestibular schwannomas. Diagnosis:
bilateral VS in a 25-year-old. That's neurofibromatosis, type 2, NF2.
Right. How does this completely change the management philosophy?
Oh, it changes everything. With sporadic VS, the goal is tumor control, maybe hearing preservation on one side. With NF2, the patient is unfortunately facing eventual bilateral deafness. So the number one goal shifts dramatically to preserving useful hearing for as long as possible, potentially for decades.
So you're less aggressive with local treatment initially?
Much less aggressive. Observation is the first step, always monitoring growth and hearing. If things progress, the next step isn't immediately radiation or surgery. It's systemic therapy.
Which systemic therapy?
Bevacizumab. It's a standard first-line approach for progressing NF2-related VS. It's an anti-VEGF antibody.
And the response rates?
Pretty good, actually. Studies show about a 50 to 60% hearing response rate, meaning hearing stabilizes or improves. And about half of patients might see some tumor shrinkage. It buys time, sometimes years, delaying the need for local therapy.
Okay, but let's say bevacizumab fails or isn't an option, and radiation becomes necessary for one or both sides. You wouldn't use the 12.5 gray single fraction SRS you just described.
No, absolutely not. In NF2, when we absolutely have to radiate, especially if it's the only hearing ear, we move away from single fraction SRS. The risk, even if low, is too high when you're trying to preserve the last bit of hearing.
So what's the approach?
We use fractionation. Fractionated stereotactic radiosurgery, or even fractionated radiotherapy. For example, a common regimen is 18 gray delivered in 3 fractions.
Why fractionation?
The idea is that fractionation allows the normal tissues, particularly the cochlea and the cranial nerves, more time to repair between doses compared to a single large dose. This theoretically gives us a better chance to spare function, especially hearing, while still controlling the tumor. It's all about that long-term hearing preservation goal.
Okay, teaching pearl number 2. NF2 management is a different ballgame. Prioritize hearing with observation, bevacizumab, and if radiation is needed, use fractionation like 18 grays in 3 fractions to minimize toxicity and delay deafness.
Exactly right. It's a marathon, not a sprint.
All right, let's move on to meningiomas, case 2. A 62-year-old man, he had surgery for a large parasagittal mass. The surgeon notes it was a subtotal resection, Simpson grade 4. Pathology comes back. Atypical meningioma, WHO grade 2. What's your adjuvant recommendation?
Okay, WHO grade 2, and importantly, a subtotal resection. That combination puts him squarely in the high-risk category according to classifications like those used in RTOG 0539.
A recommendation.
Adjuvant radiation therapy is definitely recommended. Mandatory, really, in this situation to improve local control.
And the dose. What evidence supports it?
The standard dose based on RTOG 0539 for this high-risk group is 60 gray in 30 fractions.
60 and 30. Why that dose? What did the trials show for that group?
Well, even with 60 grays, the 3-year progression-free survival, or PFS, for the high-risk group in 0539 was only around 59%. So it highlights the aggressive nature of incompletely resected grade 2 meningiomas. Lower doses were clearly insufficient. You need that higher dose to have a decent chance at long-term control. It contrasts with the intermediate risk group, like a completely resected grade 2s, who did better.
Okay, 60 gray it is. But during planning, you realize you can't safely deliver 60 grays without exceeding the tolerance of the optic chiasm. Even with IMRT, you're hitting a wall. How do you defend compromising down to 54 gray?
Right, this happens. Patient safety trumps protocol dose. If a critical organ at risk, especially something like the optic chiasm or optic nerves, absolutely cannot tolerate 60 gray safely, then de-escalating to 54 gray is a reasonable, necessary compromise.
But it is a compromise. What do you do then?
First, you absolutely have to counsel the patient. Explain that while 54 gray is safer for their vision, it does carry a higher risk of the tumor coming back compared to the 60 gray goal. This means they'll need closer MRI surveillance.
Any technical options you'd explore first?
Definitely. Before settling on 54 gray, I'd explore everything. Can we use protons? Their sharper dose fall-off might spare the chiasm. Can we do a simultaneous integrated boost, an SIB, where we give 60 gray just to the highest risk residual nodule and maybe 54 gray to the rest of the bed? You explore those advanced techniques first. If none work, then 54 gray is the fallback, planned with very tight margins.
Okay, let's define those volumes for this parasagittal grade 2 residual getting 54 gray. GTV, CTV, PTV.
Okay. The GTV, gross tumor volume, is the enhancing residual tumor seen on the post-op MRI, plus the surgical bed as defined by the surgeon's clips or cavity changes. The CTV, clinical target volume, is typically a 1 to 2 centimeter expansion on the GTV. But critically, you have to edit this carefully. Exclude bone, air, brain structures clearly not involved. For a parasagittal tumor, you specifically include the adjacent involved sinus wall and the nearby dura mater.
What about dural tail?
Good point. Only include nodular dural tail enhancement in the CTT. Thin, linear dural tail is often just reactive inflammation, not tumor, so we typically exclude that to minimize irradiated volume.
Takes sense. And PTV?
PTV is a standard 3 to 5 millimeter isotropic expansion on the CTV. This accounts for daily setup variations, internal motion.
Got it. Teaching parole number 3. Subtotal resection of a WHO grade 2 meningioma is high risk, typically needing 60 gray.
Yeah.
If OAR limits force of reduction, 54 gray is acceptable but needs careful counseling and follow-up. This contrasts with intermediate risk, like a gross total resection of grade 2, where 54 gray or even observation might be considered.
Correct. The resection extent is key for risk stratification.
Which brings us to the twist. Same 62-year-old man, same WHO grade 2 pathology. But this time, the surgeon achieved a Simpson grade 1 resection. Complete removal, no visible residual tumor. Now, what's the recommendation? Observation or adjuvant radiation?
Yes. This is the classic controversial scenario in meningioma management, complete resection of a grade 2. There's genuine equipoise right now between observation versus adjuvant radiation, typically 54 gray and 30 fractions.
So it's debatable. What are the ongoing trials looking at this?
Exactly. This very question is being studied in major phase 3 randomized trials, specifically the ROAM trial in Europe and the NRGBN 003 trial in North America. We're waiting for those results to guide us definitively.
In the meantime, how do you counsel this patient? What data do you lean on?
You present both sides. You can reference the intermediate risk group data from RTOG 0539. Those patients, mostly completely resected grade 2s treated with 54 gray, had very good outcomes, something like 94% 3-year PFS. So you can argue that adjuvant radiation offers excellent control.
And the argument for observation?
The argument for observation is avoiding the potential late toxicities of radiation neurocognitive effects, radiation necrosis, secondary malignancies, however small the risk, especially since a good number of these patients might not recur even without radiation. It becomes a shared decision-making discussion. You outline the recurrence risk with observation versus the controlled benefit and toxicity risk with radiation. The patient's values and risk tolerance become very important.
Okay, teaching parole number 4. Completely resected WHO, grade 2 meningioma management is controversial. Observation and adjuvant 54 gray are both reasonable options, currently being compared in trials like ROAM and NRGBN 003. Shared decision-making is essential.
Precisely. We need those trial results.
Let's shift gears to vascular. Third case, a 30-year-old man with a history of seizures. His MRI shows a 2-centimeter arteriovenous malformation, an AVM. The tricky part, it's located right near the motor strip. He's referred for SRS. What dose do you prescribe and why?
Okay, an AVM near eloquent cortex, the motor strip. The goal is obliteration, but we have to be careful. While maybe 20 gray is often cited for optimal obliteration of small AVMs, the location here demands caution.
So you'd reduce the dose?
Yes. I would prescribe 18 gray to the margin. This dose still offers a good probability of obliteration, maybe slightly lower than 20 gray, but significantly reduces the risk of causing radiation-induced deficits like weakness, given its proximity to the motor cortex. It's a balance.
18 gray for balance. Good. When planning this SRS, what's the single most critical dosimetric parameter you need to control to minimize the risk of radiation, necrosis, or other adverse effects?
That would be the V12. The V12 is the total volume of normal brain tissue receiving 12 grays or more.
Why is V12 so important?
There's a lot of historical data showing a clear dose-volume relationship. If that V12 volume gets too large, say above 8 to 10 cubic centimeters, the risk of symptomatic adverse radiation effects, especially radiation necrosis, starts to climb significantly, maybe above that acceptable 3 to 5% level. So keeping the V12 low, under 8 to 10 cc, is probably the single best predictor of a safe SRS treatment for AVMs.
How do you ensure precision in targeting, especially near the motor strip? What imaging and planning tools do you use?
Precision is everything here. You absolutely need to fuse the high-resolution MRI with a 3D rotational digital subtraction angiogram, a DSA.
Why the DSA?
The DSA is the gold standard for defining the AVM nidus, the actual tangle of vessels that is the target. MRI alone can sometimes overestimate or underestimate the nidus. Fusing them ensures you're targeting precisely what needs to be treated and, just as importantly, excluding normal feeding arteries and draining veins from the high-dose volume.
Any other imaging for the motor strip location?
Yes, given the location, I definitely want to incorporate diffusion tensor imaging, DTI, if possible. This helps visualize the corticospinal tracts, the motor pathways. You can then actively shape the dose distribution to minimize dose spilling onto those critical white matter tracts.
Very important. Now, counseling. SRS for AVM isn't an instant cure. What timeline do you give the patient for obliteration, and what do you say about the hemorrhage risk during that time?
This is crucial counseling. I'd explain that SRS works slowly. The blood vessels gradually thrombose and scar down over time. Complete obliteration typically takes 2 to 3 years.
2 to 3 years. And the bleeding risk.
Critically, during that entire 2 to 3 year latency period, the AVM can still bleed. The annual risk of hemorrhage is likely reduced compared to baseline after SRS, but it's definitely not zero until we confirm obliteration angiographically. So they still carry that risk until cure is proven.
How do you follow up and confirm cure?
Follow-up involves serial MRS, maybe at 1 year, 2 years, but the definitive test is a formal catheter angiogram, usually performed at the 3-year mark post-SRS. Only a negative angiogram confirms complete obliteration and cure.
Okay, teaching pearl number 5. For small AVMs near eloquent cortex, 18 gray SRS balances obliteration and safety. Controlling the V12, keeping it under 8 to 10 cc, is key to minimizing toxicity. Patients must understand the 2 to 3 year latency to cure and the persistent hemorrhage risk during that period.
Absolutely. Managing expectations is vital.
Now, the big AVM dilemma. A different patient, 25 years old, completely healthy. An MRI for unrelated reasons finds an incidental, unruptured 2-centimeter AVM. Should he even be treated? How do you counsel him using the Aruba trial?
Yes, the Aruba trial. That really threw a wrench into managing unruptured AVMs. The trial randomized patients with unruptured AVMs to either medical management alone or upfront intervention, which could be surgery, embolization, SRS, or a combination.
And the headline result?
The initial publication, with about 33 months median follow-up, showed that the group getting intervention had a significantly higher rate of stroke or death compared to the medical management group, about 3 times higher risk in the short term.
That sounds bad for intervention.
It does on the surface, but counseling requires digging deeper. You have to acknowledge the Aruba result upfront intervention carries short-term risks. However, you also have to discuss the major criticisms of the trial.
Such as?
Well, the follow-up was quite short, especially for a 25-year-old who has potentially 60 or 70 years of life ahead of them. Critics argue it didn't capture the potential long-term benefit of preventing hemorrhages over a lifetime. Also, the intervention arm was very heterogeneous. It lumped together neurosurgery for complex AVMs, embolization, and SRS. Many felt the risks were driven by the more invasive procedures or higher-risk AVMs included, and perhaps the results for low-risk interventions like SRS for small, accessible AVMs might be different if analyzed separately.
So how do you synthesize that for the patient? Treat or not treat?
It comes down to balancing risk profiles. You explain the short-term procedural risks highlighted by Aruba, but you also explain the estimated cumulative lifetime risk of hemorrhage if the AVM is left untreated, which for a young person can be substantial, maybe 50% or higher over their lifetime, plus the associated morbidity and mortality of a bleed. For a young patient with a low-grade accessible AVM suitable for SRS, many centers still offer intervention, arguing the lifetime benefit outweighs the short-term risk. But it's a very individualized decision, heavily dependent on the AVM characteristics and the patient's own risk tolerance after hearing all the information.
Teaching pearl number 6. The Aruba trial showed higher short-term risk with intervention for unruptured AVMs, but its limitations, short follow-up heterogeneity, are debated. Counseling young patients involves balancing these short-term procedural risks against the potentially high cumulative lifetime risk of hemorrhage if left untreated. SRS is often still considered for low-grade lesions.
It's one of the toughest counseling scenarios we face.
Let's turn to the pituitary region. Case 4. A 55-year-old woman presenting with bitemporal hemianopsia, classic visual field defect. MRI shows a 3.5 centimeter non-functional pituitary macroadenoma. It's pushing up on the optic chiasm with less than 2 millimeters of separation. She undergoes surgery, but it's a subtotal debulking. Significant residual tumor remains, still right up against the chiasm. What's the radiation recommendation, and why is fractionation preferred over single-fraction SRS here?
Okay, large residual non-functional adenoma critically abetting the optic chiasm, less than 2 millimeter separation. This immediately rules out single-fraction SRS. The recommendation has to be for fractionated external beam radiation therapy.
Why does that close proximity absolutely mandate fractionation? Explain the radiobiology.
It's all about the tolerance of the optic apparatus, the nerves, and the chiasm. These are serial structures, meaning damage to even a small part can cause significant irreversible vision loss. They have a very limited tolerance to high single doses of radiation. Typical SRS doses used for pituitary tumors, maybe 12 to 16 gray for non-functional or higher for functional, would exceed the safe single fraction limit for the chiasm, which is generally considered around 8 to 10 gray maximum point dose.
So SRS is too risky for vision. How does fractionation help?
Fractionation allows us to exploit the difference in repair capacity between the tumor and the normal neural tissue. By delivering the dose in small daily fractions, typically 1.8 to 2.0 gray per day, we allow the optic nerves and chiasm time to repair sublethal damage between treatments. This lets us deliver a much higher total dose to the tumor, enough for long-term control, while keeping the dose per fraction and the cumulative dose to the chiasm well within safe limits. The standard limit for the chiasm with conventional fractionation is a maximum dose of less than or equal to 54 gray.
Okay, so fractionated therapy it is. Outline your plan specifics. Technique, dose, volumes.
I'd use intensity modulated radiation therapy, IMRT, for its ability to conform the dose tightly to the target and spare the surrounding normal structures. For a non-functional adenoma, the standard dose is 45 gray delivered in 25 fractions.
45 and 25. Control rates.
That dose gives excellent long-term lodal control, usually greater than 90%. For volumes, the GTV is the enhancing residual tumor on the post-op MRI. We use very tight margins in this area. A CTV margin of maybe just 1 to 2 millimeters and a PTV margin of 2 to 3 millimeters is typical. Keep the treated volume as small as possible.
And the main long-term side effect you counsel for. Follow-up.
The primary long-term risk is hypopituitarism. Radiation inevitably affects the function of the remaining normal pituitary gland over time. So patients need lifelong endocrine follow-up, regular hormone level checks, and potentially hormone replacement therapy starting years after treatment. Imaging follow-up starts with an MRI 3 to 6 months after finishing radiation, then typically annually after that.
Perfect. Teaching pearl number 7. Close proximity, less than 2 to 3 millimeters, of a pituitary adenoma to the optic chiasm mandates fractionated RT, usually 45 grays in 25 fractions for non-functional tumors, keeping chiasm max dose under 54 gray. SRS is reserved for smaller tumors with clear separation from the optic apparatus.
That separation is the key determinant.
So let's take that point. Twist time, a different patient. They have a 1.2 centimeter growth hormone, GH-secreting adenoma causing acromegaly. After surgery, there's a residual tumor, but crucially, it's located 5 millimeters away from the optic chiasm. And what's the radiation recommendation?
Now things change. With 5 millimeters of separation, we have a safe distance from the optic chiasm. Single fraction stereotactic radiosurgery, SRS, becomes an excellent and often preferred option.
Why preferred here, especially since it's a functional adenoma?
2 reasons. 1, the safe separation allows it. 2, for functional adenomas like this GH-secreting one, the goal isn't just tumor control, it's achieving endocrine normalization, stopping the excess hormone production. SRS allows us to deliver a higher biological dose in a single shot, which tends to be more effective for shutting down hormone secretion compared to conventional fractionation.
So a different dose strategy for functional adenomas via SRS. What dose?
Yes, we use higher marginal doses for functional adenomas, typically in the range of 20 to 25 gray prescribed to the margin. This higher dose is needed to maximize the chance of achieving biochemical remission.
20 to 25 gray. And what's the timeline for that remission? Is it immediate?
No, definitely not immediate. Similar to AVMs, the effect is delayed. Biochemical remission after SRS for functional adenomas usually takes time, often 2 to 5 years. So you must counsel the patient that they'll likely need to continue their medical management for acromegaly, working closely with their endocrinologist during this latency period until the radiation takes full effect.
Okay, teaching pearl number 8. If residual pituitary adenoma is safely separated, 3 to 5 millimeters or more, from the optic apparatus, single fraction SRS is often preferred, especially for functional tumors. Doses are higher, 20 to 25 grays, aiming for hormonal control, but biochemical remission is delayed, 2 to 5 years, requiring ongoing medical co-management.
Right. Dose and goals differ significantly based on function and location.
Final case. Let's talk functional radiosurgery for pain. We have a 70-year-old woman with a 2-year history of severe facial pain. It's classic. Lancinating electric shock-like pain in the right V2 and V3 distributions, triggered by talking, chewing. She's failed multiple medications, carbamazepine, gabapentin, etc. Her MRI brain is negative for any tumor or vascular compression. What are the procedural options for this refractory classic type 1 trigeminal neuralgia, or TN?
Okay, medically refractory classic TN procedural options fall into a few categories. There's microvascular decompression, MVD open surgery to physically move any compressing blood vessel off the nerve root. It's often considered the most durable option but carries surgical risks. Then there are percutaneous rhizotomy procedures using needles to intentionally damage the trigeminal ganglion or rootlets via heat, radiofrequency, chemical, glycerol, or mechanical means, balloon compression. And finally, there's stereotactic radiosurgery, SRS, which offers a completely non-invasive way to create a lesion on the trigeminal nerve root.
She decides against open surgery and opts for SRS. Walk me through the SRS plan. What's the target, the dose, and the key counseling points about efficacy and side effects?
The target for TN-SRS is the trigeminal nerve root itself, specifically near its entry into the brainstem, the root entry zone. We typically place a single, small isocenter, usually a 4 mm shot, targeting the nerve 2 to 4 mm anterior to the pons.
Why that specific spot?
That location is thought to be a sweet spot, balancing the chance of hitting the pain fibers effectively while trying to minimize the dose to the part of the nerve responsible for normal sensation, thereby reducing the risk of facial numbness or hypoesthesia, which is the main side effect.
And the dose?
The dose is quite high for SRS. We typically deliver a maximum dose of 75 to 80 gray to the center of that shot.
75 to 80 gray max dose. Outcomes for classic type 1 TN.
For classic paroxysmal type 1 pain like hers, SRS works pretty well initially. You can usually quote around a 70 to 80% chance of significant pain relief starting within a few weeks to months.
But there's always a but.
The buts are important. First, about 10 to 20% of patients will develop some degree of bothersome facial numbness or altered sensation as a side effect. Second, the pain relief isn't always permanent. Durability can wane over time, maybe 50% recurrence by 3 to 5 years, sometimes requiring retreatment or another procedure down the line. And third, the benefit isn't instant. It takes weeks, sometimes months, for the pain relief to fully kick in.
Okay, important counseling points. Teaching Pearl number 9. For classic type 1 TN, SRS targeting the root entry zone with 75 to 80 gray max dose offers high initial pain relief, 70 to 80%, but comes with a risk of numbness, 10 to 20%, and declining durability over years. Pain relief is delayed.
Patient selection and counseling are key.
Absolutely. Which leads to the final twist. Same patient, same age, same location of pain, but instead of classic electric shocks, she describes her pain as mostly constant burning, aching, perhaps with some sharp jabs superimposed. This sounds more like atypical or type 2 trigeminal neuralgia. How does this dramatically change your counseling about SRS efficacy?
Oh, that changes the conversation significantly. If the predominant pain pattern is constant burning, aching type 2 features, then SRS is much, much less likely to be effective.
How much less effective?
The success rates really drop off, maybe less than half the success rate compared to classic type 1 pain, perhaps only 30 to 40% achieving meaningful relief, and often it's less durable too. You have to be very upfront about the limited potential benefit.
Why is SRS so much less effective for that type of pain? What's the thinking?
The prevailing theory is that classic type 1 pain might be related to ephaptic transmission or focal demyelination at the root entry zone, which the focused SRS lesion can disrupt. The constant burning, aching pain of type 2 TN, however, is thought to reflect more widespread nerve damage, central sensitization, or maybe differentiation pain mechanisms. These are likely less amenable to a single focal lesion created by SRS. It's just not targeting the underlying pathophysiology as effectively.
So managing expectations is critical.
Absolutely critical. For atypical facial pain or type 2 TN, stressing the need for realistic, often quite limited, expectations regarding SRS benefit is paramount to avoid patient disappointment.
Teaching Pearl number 10. Patient selection is crucial for TN SRS. Efficacy is highest for classic type 1 paroxysmal pain. It is significantly less effective for atypical type 2 neuralgia characterized by constant burning or aching pain. Counsel patients accordingly.
Couldn't agree more. Huge difference in expected outcomes. Hashtag recap and summary.
So we've covered a lot of ground 5 complex CNS cases. From vestibular schwannomas in NF2 through meningioma grading and resection debates, AVMs and the aerobia controversy, pituitary adenomas hugging the chiasm, and finally trigeminal neuralgia types.
Yeah, quite a tour.
I think the big takeaway, really, is how success hinges on this deep interplay between understanding the detailed anatomy, leveraging the right technology, whether it's SRS or fractionated IMRT, and applying radiobiological principles guided by solid evidence. choosing the right dose, the right fractionation, respecting those critical OAR constraints.
Absolutely. It's clear that there's no one-size-fits-all approach. You saw how the strategy shifted dramatically for vestibular schwannoma when NF2 was diagnosed, prioritizing hearing above all else, or how AVM management requires balancing obliteration probability against the V12 to protect function. And then managing those controversies like grade 2 meningioma after complete resection or the unruptured AVM really requires nuanced, evidence-based discussion with the patient. It's about tailoring the treatment very specifically.
Exactly. It's about applying these principles case by case. Well, that brings us to the end of this run-through. Really appreciate you walking through these complex scenarios.
My pleasure. It was a great review of key CNS topics and decision points.
And for you listening, you can complete practice oral boards at radontsmartlearn.com. That's pronounced radontsmartlearn.com. Thanks for tuning in.